I had a very different take on this one. I thought we were not talking about a solo practitioner kind of a setup. This, we are more into teaching hospital kind of a setup.
Sir, in the college also, like residents are there.
True.
They are just observing how we counsel the patient. But we cannot leave everything on the residents.
I agree.
And most of the time they are so busy in writing case sheets, doing rounds, that they take this thing also like routine work. They will just routinely, they will just counsel. They will not go into the minute details of the counseling. So that is what I have seen in my college.
I agree. I mean, but what I'm actually trying to stress is...
But we cannot completely absolve the responsibility of the residents from the counseling
they should do, but they should be under observation.
That your study that has been given, I don't know how far that is been logically correct because only 50. We can discuss at the end of the session.
Thank you, sir. Thank you, sir.
We can go ahead to the next topic, madam, please.
Topic of independent OPD patients for residents in favor for the residents to see independent patients. I would begin with a big yes, because the sole purpose of residency is to gear up for the real world, so a strong foundation is needed where the residents need to be trained to see and treat patients independently under guidance. Especially ophthalmology being a clinical branch, clinical skills are essential and just theory is not enough. So the study published in 2017 gives the definition of resident as a creative doctor in training whose skills have to be sharpened and mind fostered for better patient care rather than a passive student whose duty is to serve the department and absorb knowledge in the process. Another study published in 2008 pointed a few fallacies of the current postgraduate programs, saying that it does not train the residents in modern ophthalmic examination, so they were not confident of independent practice. The Medical Council of India recommends that there is the goal of producing competent specialists who are expected to master most of the competencies to enable them to carry out their professional duties ethically. So does the International Council of Ophthalmology, which says that the preamble of the curriculum for education of an ophthalmic specialist is the objectives being designed to provide a structured program of learning that facilitates the acquisition of knowledge, understanding, skills, and attitudes to a level that is appropriate for ophthalmic specialists who have been fully prepared to begin their career as independent consultants in ophthalmology. So how do we prepare these independent consultants in a way that patients are not at risk, there is some form of supervision, and we reach a solution for the roadblocks? If the consultant supervises the resident completely, the residents are not completely self-confident, and the patient would also prefer to be seen by the consultant in the presence of the consultant. So what we can aim for is a guarded independence. So how do we reach this aim of guarded independence? There is a suggested solution for achieving these objectives. Starting with the first year of residency, in the first 6 months, we can start with an orientation program, which is known to lay a strong foundation stone so that eventually the goal of independent patients in the OPD can be achieved. Along with it, during the orientation program, it is reinforced that the residents should never dispose of patients without a proper plan of action and should be able to identify the red flag special situations where they will never dispose of without consulting the senior. So the first 6 months, along with the orientation program, the resident should be spending 1 month in each specialty, along with observation of refraction in OPD. At the end of 6 months, they can conduct a practical class and demonstration on refraction, followed by a test on refraction. Hereafter, the goal of performing independent refraction is reached. In the next 6 months of the first year of residency, the residents can go on with an independent refraction, can sit in the OPD under guarded independence with the senior resident, can start observing procedures like applanation tonometry, gonioscopy, indirect ophthalmoscopy, slit lamp biomicroscopy, perimetry, biometry, ultrasound B-scan. For the OPD, the first 3 months, they only observe how the patients are being treated. The next 3 months, they can start seeing independent patients, minimum 10 patients that can be seen by them and then discussed with the senior. The second year residency, the OPD is again with the senior resident. Beginning of second year, we can conduct a practical examination to test whether the diagnostic procedures which were observed in the last 6 months, whether the resident is certified competent enough to do them independently. If they are, they can start performing the diagnostic procedures. The study in 2005 claims that independent performance of diagnostic procedures is essential for resident training. For OPD patients, they can start seeing independent patients minimum 20, while the senior resident is on watch out while allowing independent patient, and they can intervene and take over whenever necessary. The third year residency, the first 6 months, the resident can sit with the senior consultant and see minimum 30 patients suggested. It is up to the consultant depending on the competence that the resident has achieved. The next 6 months, the last 6 months of the residency, the resident can graduate to seeing independent OPDs. This is also in line with the ACGME recommendations, that's the Accreditation Council for Graduate Medical Education by the American Board of Ophthalmology. So advantages of independent OPD for the resident, they become confident in handling clinical situations, so they may not always be compelled to seek additional training. There are improved diagnostic and examination skills. Intervention on their own patients is one way to ensure examination management follow-up skills are up to the mark. Improved soft skills, communication with patients, relatives, staff, colleagues, seniors, cross-consultations and interspecialties is improved. They cultivate more interest in the field, they learn proper application of the preferred practice pattern, and the final goal of taking care of 80 to 90% of patients as primary care ophthalmologists can be achieved. They learn how to go about teamwork, understand firsthand the importance of ethics, informed consent, and patient participation. For the patients, it leads to a more thorough history taking, cross-checking of examination findings, and reduced waiting time. For the institute, there is a lesser waiting time, more thorough detailed evaluation of the patients, and the day-to-day intricacies and hassles can be managed well with the help of the residents if they are more involved. Thank you.